course, when you have a fractured endodontically treated tooth and you have a ferrule which is maintained, then in such cases, it's always better to have. So this is the ferrule which is maintained all over, the 360-degree ferrule. My postgraduates will know, all our postgraduates, it's very important. This is the kind of zirconia coping which is masking the metal here of the post and core, cast post and core, and finally you have the crown here. So that's how you have to decide. Obviously, you can't have a lithium disilicate, though it's an anterior aesthetic zone. You can't be having a lithium disilicate on this because you can't mask the underlying metal. So that's your judicious choice when you're dealing with certain situations. Obviously, implants, when you are in the anterior aesthetic zone, then you want a abutment which is probably, if it's a titanium base or it's a zirconia abutment. If it's a zirconia, then you would probably use a lithium disilicate crown. But if it's a titanium, then there are various other situations where you can have a tie base, you can have a titanium abutment, and then you have to mask that underlying metal, and the bonding systems also have to be very, very carefully used, wherein with any form of zirconia and titanium base, and when you are bonding a lithium disilicate, it's very essential. Nowadays, we have the tribochemical silica coating, which is done for the tie base. You have certain conditioning of the tie base and the zirconia bases, which are done in order to enhance. You have to use the use of a silane coupling agent after the tribochemical is done. I will show you in my next pictures the entire bonding technique, and that's how you then get the desired effect with zirconia based abutments in single tooth implant restorations. So now, how do we defend our treatment goals? It's important that we cater to the needs and expectations of our patients. It's also important that our laboratory technician understands what we desire from him, and it's our judicious choice and skill. Retention has to be, we have always been taught that the biomechanical principles of retention have to be followed. So it's very, very important that we follow those. The reduction guidelines have to be essentially in two planes, and the optimum reduction would be necessitating somewhere between 1.5 to 2 millimeters when it is a full veneer crown. Particularly, I would say zirconia require more amount of reduction. Lithium disilicate comparatively require lesser amount of reduction. In the kind of finish lines we are looking out for are heavy chamfers or rounded shoulders, no rough edges, the same kind of biomechanics which we have been always taught. When it's a veneer prep, it can be a no prep veneer, it can be a thinner, it can be a minimum prep veneer, but somewhere in the range of 0.7 to 1.5 is what we are looking out for in a veneer prep. But essentially, the margins have to be in enamel, have a proper marginal integrity. It's very, very crucial for the longevity of your restoration. Capturing the finish lines can never be undermined. We are all running the digital way, but conventional techniques also have to be properly learned. Your finish lines, now if you can see the beauty of the finish lines where it is captured here, is very, very essential when you want proper marginal integrity. The longevity and the aesthetics and emergence profile can only be achieved if you capture your finish lines and have the kind of marginal integrity which is there. You go the digital way or the conventional way, but the margins can never, never be overemphasized. You have to capture the margins and finish lines properly. Shade selection. That has been always an enigma. And proper lab communication. We are in the era of technology. So it's important for us to understand that how do we take a proper shade? All of us take the shade of the contralateral tooth, the opposing arch, if it's a central incisor, the next central incisor. But how many of us are actually taking the stump shade? That is, after the prep, you have to take the stump shade, because bringing out the color, the final outcome of the restoration from the stump shade to your restoration is the most critical part. That means if you observe, is your positive stump shade. It's a white, nice white prepared tooth. But this, if you observe, is your negative stump shade. So wherein you have discolored teeth. So you have to communicate these stump shades as well, because then that's how the play of ceramics, that's how the layering, that's how the opaquing, that's how the combination of the play of ceramics has to be judged, not just by the clinician, but the technician who is going to make or fabricate the crown for you. So apart from your contralateral tooth, the stump shade is extremely crucial to be communicated. As I said, role of bleaching. If you have discolored prep tooth, then the role of bleaching is very crucial. So in such cases, you can do external or internal bleachings and then wait for a week, as I said, and then go ahead with your preparations. So this is very, very important many a times, because if you are unable to mask that underlying discolored dentine, it is very difficult. Luting agent. Never can be undermined that the final shade outcome of a veneer, of a lithium disilicate translucent ceramic has always been dependent on the luting agent. So it's very important for us to choose our luting agent. Nowadays, there are luting navigation, that is cementation navigation apps, which are available on the Ivoclar and different type of websites. So you have trying pastes. So if specifically when you have a laminate veneer to be cemented or luted, then the trying pastes are going to give you exactly what kind of final shade outcome. So luting agents have to be properly and appropriately selected, not just for the final shade outcome, but for your bond strength and the bonding mechanism and the final strength of the ceramic that you are absolutely using. Now let's look at the brief. So when you're using a lithium disilicate as a for a veneer, then obviously you can use a light cured resin bonded resin bonded cement. When you're using a crown, that is a full veneer crown, then you're going to be using a dual cured, because obviously in a full veneer crown, the thickness is probably 2 millimeters, and the light penetration is difficult. So that's why it is important to use a dual cure resin cement. Now, mind you, when you're using dual cured, nowadays we have amine-free dual cure resin cements also, which are available, because dual cure resin cements have amine in it. And those amines, which are photoinitiators of dual cure resin cements with benzoyl peroxides, over the time, they cause discoloration. So that's why it is judicious to use your cements, particularly in the anterior aesthetic zone. Select the amine-free resin luting agent and accordingly do, particularly when you have a translucent ceramic which you're using in the anterior aesthetic zone. With zirconia, obviously it's glass ionomer, or preferably resin modified glass ionomers also can be used, because those resin modified glass ionomers have better adaptability, better strength, you have ease of manipulation, and that's why it is better to use. However, nowadays with the newer kind of zirconias which are coming, again, as I said, if you want to use a dual cure resin cement, you have to have a tribosilica coating, which is like an air abrasion. It is by Rocatec Plus. You can read more about it. That is Rocatec Plus or Cojet are the ones which are air abrasion with silica coating, and hence after this silica coating is done with air abrasion of the alumina particles, you coat it with a silane coupling agent and only then use a dual cure resin luting agent. Otherwise, using a dual cure in zirconia is absolutely of no significance, because your bond strength is particularly essential in lithium disilicate. In zirconia, a glass ionomer can serve a purpose. So as I said, bonding mechanisms are extremely technique sensitive and crucial, and you can choose a variety of cements are there in the market, but whatever is your comfort level, whatever is your choice of ceramic material, what is your treatment modality, according to that your choice of luting agent has to be done. Now, very quickly, I want to go through a little bit of the luting protocols, which are extremely essential when you have a lithium disilicate or a silica-based ceramic, wherein on the tooth, particularly, it is important that you etch the tooth with 37% phosphoric acid, and then you apply the bonding agent. But on the restoration, which is coming from the lab, it is important that you insist for a 5% hydrofluoric acid pre-etch in the lab, or you also have it at the chair side. It is available in the market. So you etch it between 5 to 10% of hydrofluoric acid pre-etch of the restoration. It is a veneer or a lithium disilicate crown. It's very important to etch it. After that, as I mentioned, the silane coupling agent has to be applied on the intaglio surface of the restoration. Then the normal protocol has to be followed. That means you have already conditioned the tooth with the bonding agent, you have cured it. Then you place the luting agent on the intaglio surface, you seat it, you light cure it for 10 seconds, you wait, you remove the excess cement, and then you finish your final cure. So this is the protocol which has to be followed very judiciously. And that's something which is very important, because your bonding is going to be your answer for your longevity of particularly your lithium disilicate restorations. The latest trends in lithium disilicate, obviously, nowadays we have, the trend is that we want stronger lithium disilicate. So we have those CAD milled and all, which have increased strength, better flexural and edge strength, and better translucency as well. This is a beautiful paper which talks about which all ceramic systems are optimal for anterior aesthetics, published in JADA, and it gives a beautiful evolution of all the all ceramic systems and how we would clinically choose what kind of all ceramic system is to be used. So now we come back to the ceramic war, when if we taper down to two basic ceramics that we are talking in rehabilitation zones, we understand that lithium disilicate is obviously the more translucent. It has a better marginal fit, but zirconia obviously is better in strength. If you see 1000 to 1200 megapascals. So that is something which, so when you have, again, we come back to aesthetics versus weaker and stronger tooth. So if you want a more rehabilitation, in the full mouth rehabilitation cases, zirconia is going to be our ceramic of choice. Sometimes if you have to use the veneering, then in copings, you can veneer the ceramics with the help of lithium disilicate. In terms of flexural strength, obviously, we do understand the risk of fractures are more higher in case of feldspathic or in case of pressed glass ceramics. But in terms of zirconia, you have less type of fracture and less risk of fracture, obviously. Even for the space that we require, for lithium disilicate, it obviously is going to be more than as per the zirconia, which we are, obviously zirconia in thinner sections can be done, but lithium disilicate requires a little thicker sections as compared to our PFM. PFM are the most, or rather I would say the least conservative of restorations, which are our gold standards. Let's quickly now browse through what are our newer trends, because all of us want to know what is new that is happening. This has been in past decade. We all understand that lithium disilicate and IPS Empress 1, Empress 2, zirconia all have evolved. The newer trends are Lisi Press by GC. That is the high density micronization. That is something which is the next generation lithium disilicate, which is coming up in the labs now, and they're using more of Lisi Press because it's a very, very beautifully translucent material and having excellent marginal adaptation. Zirconia wants to become like lithium disilicate. That's why it's becoming a little more translucent. It says I'm stronger, but I want to become a little more translucent as well to be used universally. However, it's still in a lot of research stage. We have Celtra Press as well, which is again a zirconia reinforced, stronger kind of lithium silicate ceramic, which has improved flexural strength. So these are the ones which are again now gushing into the market with newer trends and newer promises, but yet they need to be explored. So what's our dilemma? Single crown versus a fixed dental prosthesis, anterior versus posterior zone, aesthetics versus function, lithium disilicate versus zirconia. The transition is reversible. Stronger versus weaker, opaque versus translucent. Gordon Christensen, the Dion of aesthetics, speaks that particularly when you have the posterior zone, then he still prefers precious alloys. If you see gold alloys, then PFMs, then zirconias, obviously not lithium disilicate. And when it is the anterior zone, then obviously lithium disilicate is your material of choice. But all these have to be used very, very judiciously. So we cannot say that precious alloys or PFMs are dying or they cannot be used any longer just because we are blinded by ceramics. The judicious use of the kind of treatment material and the modality is extremely important. Success versus survival is gauged by fracture, chipping, secondary caries, marginal adaptation, discoloration, surface roughness, color stability, anatomical form to produce the aesthetic realism, conservative tooth preparation, versatility in use, predictability in performance, and aesthetics versus function. These are all the things which we are looking out, whether we are looking for a success versus survival kind of a restoration in our practice. We know that biology is blending with technology. And we also want to emulate nature. That means we want to create lifelike restorations. Documentation has become an integral part of bioemulsion. That means that we are in a trend of technology and using a DSLR, photography, and communicating with our technician. We also have shade navigation apps which have come up by IPS Emacs. We have Vita AZ Shade Guide, which is by a click of a button, we will be able to get the shade. Nevertheless, we must know our basic principles of shade matching with a regular Vita shade guide as well. Yes, these are all going to be augmenting or supplementing our basic knowledge, but the basic principles of shade matching have to be followed. Lastly, what are the points that we are going to remember when we are making the right choice? To begin with, in the center, we have to understand what is our zone of rehabilitation. That means we have the anterior or the posterior zone that we are going to rehabilitate. Then we have the amount of tooth reduction required. Where is our margin placement? What is the smile line and the desire of the patient? What is the abutment tooth shade that we have to communicate with ourselves and our laboratory technician? This is the laboratory technician and expertise that we are looking out for, and communication extremely important. And then finally, we have the type of luting agent, which is very, very important. So we have the type of luting agent, and finally, we have the occlusion and parafunction, which is very, very crucial in such cases. You have to understand that occlusion is of paramount importance, and you have to understand that that is important for us to gain in our mind. So quickly, we are going to go through that zone of rehabilitation, amount of tooth reduction, marginal placement, smile line, abutment tooth shade, laboratory skills and expertise in communication, the type of luting agent, occlusion, and parafunction. We have to look deep into nature, and only then we will understand everything better. We have to change our conventional and conditioned thought process. We have to broaden our horizons. I believe failure is predictable. Success isn't. So what is success dependent on? I must say it all begins with you. Thank you so much for my patient hearing. I hope that this lecture, which I have the time constraints, I would have probably spoken volumes on ceramics, but with the time constraints, this is the gist of what I could share with you with my clinical knowledge and practice. I hope to see you once again.
Thank you so much, ma'am, for the excellent seminar. Very quickly, we would be having the question and answer session. I'd probably give our participants about 5 minutes of time. In the meanwhile, ma'am, I request you to kindly stop your screen share. Friends, we have 5 minutes. And in this 5 minutes, I'd like to introduce to you on the next webinar that Dentist Channel would be hosting. Our next webinar is on the topic catalyzing implant dentistry with digitally guided surgery. Once again, we have a very good speaker and a very renowned speaker, Dr. Sanjay Asnani, who would be delivering this live webinar. I'd love to have each and every one of you participating in this live webinar as well. So if you're interested, you can look up to the registration link in the chat box. Thank you so much. Thank you, Siddiq. Ma'am, we can now come back to your presentation. Thank you so much, ma'am. Ma'am, are we ready to start with the live Q&A?
Yes.
Thank you so much. So friends, moving on with the very interesting part of the live webinar, that is the live question and answer session. Moving on with the first question. The first question is from Dr. Akib, who's asking, how do we fill cracks in ceramics?
Okay, so now basically it is a ceramic repair system that is there depending upon what is the reason of your crack. You need to find out what is the depth of your crack, and there are ceramics repair systems which are available. Again, they are particularly based on the silane coupling agents and the tribochemical silica coating, which which form the covalent bonds, and that's how a specific ceramic repair system kit is available for filling up your ceramic cracks. Nevertheless, it is important that the depth of the crack has to be, only if it's superficial, you can do it. Otherwise, it is better to repeat your crown.
Thank you. I hope, Dr. Akib, the answer to your question was answered. Moving on with the next question, we have a question by an anonymous attendee. Ma'am, an insight about tribochemical used to bind zirconia. Please explain.
Sure. So, primarily, silane coupling agents are the ones which are particularly used for silica-based ceramics. That means lucite, and we are talking about lithium disilicate. However, with the bonding systems, what we are using of the dual cured or the light cured systems, we have to use a silane coupling agent. But when we are looking at a metal-based restoration, or when we are looking at a zirconia, which are non-silica based ceramics, then particularly in those kind of situations, we have to use the tribochemical silica coating. Now, what does that mean? Tribochemical silica coating is an air abrasion of alumina or silica particles. It can be done chair side with Rokatech Plus or Cojet. These are the devices which are available, or you can do it with laser etching. So all these things, what they do is they create a oxide layer on the zirconium or the metal layer, and then they are coated with the silica particles. Now these silica particles are bonded with the silane coupling agent which is on top of it, again coated, and only then you can use the dual cure resin system, dual cure resin luting agent system. However, the dual cure resin systems cannot be used if you do not do the tribochemical silica coating.
Thank you.
They are available in India under the name of Rokatech Plus, marketed by 3MSP. And the cost is around 85,000 to 1 lakh. And it's a chair side thing. It can be done as a laboratory procedure as well. It does not affect the fit. In fact, enhances the fit, because if you're particularly using the latest trends of zirconia, or when you're using a tie base in an implant restoration and you want a veneering ceramic on it like a lithium disilicate, then it is essential for you to do this tribochemical silica coating. Very, very crucial.
Thank you, ma'am. Moving on with the next question, we have a question once again from an anonymous attendee. What type of ceramics will you advise for better aesthetics, Emacs or feldspathic porcelain?
Feldspathic porcelain is a layering ceramic. It does not have the kind of strength required. So when we are talking about purely layering, you can use feldspathic ceramic. But when it is restoration in the in the anterior aesthetic zone, then yes, it is Emacs.
Thank you so much. Moving on with the next question, we have a question from Dr. C.J. Thomas. Would you prefer laminates on canine and canine guidance occlusion?
If it is a canine guided occlusion, no. Then I am a more conservative kind of a person, wherein in that case, I would not give a laminate in a canine guided occlusion. I would rather give a full coverage restoration.
Thank you. Moving on with the next question, we have a question from Dr. Vishwas Bhatia. Considering no tooth reduction options like pro veneers, do you think it is viable option in comparison to minimum prep veneers?
Yes, definitely. If the kind of emergence profile and the contour which is desired is obtained with no preps, definitely, because we are going towards more conservative dentistry where conservative is the mantra. So yes, definitely.
Thank you. Moving on with the next question. Once again, a question from an anonymous attendee. Can you please elaborate on the sandwich technique?
Sure. So I spoke to you about the underlying tooth which may be discolored. The dentine may be discolored. The reasons could be tetracycline stains. It could be endodontically treated tooth. It can be internal decay, various reasons. Now, when you want, particularly when you want in the anterior aesthetic zone, a lithium disilicate ceramic to be used, and you don't want bleaching, because probably in that you don't want to consider bleaching, then in that case, you would want to use an opaquer, a thin layer of opaquer, over which you will use a thin layer of composite resin, so that you're going to be lightening the shade of the underlying tooth, and over which then you can use your lithium disilicate ceramic. So that's called as the sandwich technique.
So much. Moving on with the next question, we have a question from Dr. Yati from Egypt. I have understood composite materials are good alternatives to ceramic crowns. I have been advised to use composite materials. What do you think of composites?
Well, I think composites are good restorative materials, but there's nothing unparalleled. They're unparalleled to the kind of aesthetics that ceramics would offer. So composites, I would say, are composites also discolor with time. The bonding mechanism with composites also is a little more technique sensitive. So in such cases, composites can be used in specific cases, but they may not be termed as long-term restorations. If you're talking about long-term restorations, and when you're talking about translucency that you desire, I think ceramics are unparalleled.
Thank you so much. Moving on to the next question, a question from Dr. Indrajit Sharan. How does Emacs layering help in zirconia layering?
Okay, so it's not zirconia layering. Basically, what happens is that when we are talking about aesthetics, which is of a particular demand, let us say it's a first premolar, a second premolar, and you want aesthetics as well as strength. So but that case, you want to use an underlying zirconia coping, and you want to layer it with Emacs veneering. So you're getting the strength as well as you're coupling it with aesthetics, because zirconia alone is not going to give you that translucency. Zirconia, however translucent it is trying to be now, the latest trend is that we have translucent zirconias, but still it's not going to be paralleled with the lithium disilicate. So in cases where you cannot use primarily only lithium disilicate because of strength constraints or because of occlusion, then it is better to give a zirconia coping, and over which you're going to give a Emacs layering, instead of a traditional PFM crown, which we have been using conventionally. And obviously, compared to a traditional PFM crown, a zirconia coping with an Emacs layering would be better.
Thank you so much. I hope your question was answered, Dr. Indrajit. Moving on to the next question, a question from Dr. George Hoffman from Germany. What do you think about dental implants that are getting converted into ceramic implants? Since I am a titanium implant user, do we need to prepare for ceramic implants now?
So now that's a completely different topic of debate, I would say. And I would say that ceramic implants are still in the stage of research, because ceramic implants, I would say, they are osteoconducive materials as opposed to titanium, which are bioinert or biocompatible materials. So when we are talking about strength and when you're talking about longevity, I don't know whether ceramic implants are still going to stand the test of time. We are dealing with a lot of surface coatings, biomorphogenic proteins, which are layered on titanium implants. Currently, in the scenario of research, I would say titanium implants still are the mainstay, and ceramic implants still have to stand the test of time.
Thank you. Maybe we could have another live webinar, especially on ceramic implants.
Absolutely.
Okay, moving on to the next question. A question from an anonymous attendee. Ma'am, can you please give insights about the SNA app for shade match? Can you please explain?
Sure. So SNA app is the shade navigation app. Now, all of us know that we have the conventional way of taking a shade. That means we're using the Vita is easy shade, Vita shade guide, or we are, if some of us have the Vita easy shade guide. Now, shade navigation app is which is developed by the Ivoclar, or it is developed by the Ivoclar system, and that app, you can download that app on your phone, and then you can click a picture and you can get the details which have to be incorporated in that app, and that will directly give you the shade. I again want to remind that this is not a foolproof system, but this can be used as an adjunct to probably reinforce your naked eye evaluation of shade match.
Thank you, ma'am. Moving on to the next question. We have a question from Dr. Oways Diku. What is the relationship What is the relation of shade of tooth color with face complications or color? How can I select a better shade?
Now, depending, if you're talking about complexion and if you're talking about the face complexion and the shade match with the face complexion, I think we go back to our BDS days when we have been taught about the personality factor that has to be covered, and the dentogenic concept that has to be covered, wherein obviously when you have a lighter complexion, then you have lighter shades, more translucent shades of your ceramic, and you have darker complexions, then you have slightly darker shades. However, I think it's a absolutely personal preference. So if you have a darker complexion person who are insisting on whiter teeth, I think you have to go with what the patient's preferences are if you're not violating the aesthetic and scientific principles.
Thank you so much. Moving on with the next question, a question from Dr. Sitaram Prasad Kasina. More than 6-unit bridge with more than 2 pontic spans. Still you prefer zirconia or PFM? What is preferred?
It's only PFM. As I said, PFM cannot die because you cannot have such long span bridges with zirconia. Zirconia can be limited to 3 unit. Beyond 3 unit, I don't think zirconia can stand the test of time. So if it is a long span, then I would insist that if such a long span, then you give a PFM, but with a precision or a semi-precision attachment again, because we're not just talking about the longevity of the PFM as a restoration, but we're also talking about the health of the stomatognathic system, the health of the abutment tooth. So in such long span bridges, it's important for us to have a semi-precision attachment as well, particularly with a PFM only.
Thank you so much. Moving on with the next question. A question from Dr. Sankalp Bhandarkar. Brookzir crown is said to be indestructible as marketed by some laboratories. Ma'am, is it needed to rehab patients with such high strength crown?
I would consider that instead of giving a Bruxer to a parafunction patient, I would rather first treat the parafunction of the patient. I would treat the patient with a splint and with a night guard appliance, try to break his habit, because when I'm talking about Bruxer, I need to understand that I need to be kinder to the opposite dentition also. So this Bruxer has to be very, very, judiciously used. So let's just talk about more holistically trying to rehabilitate the patient and trying to cure the patient particularly, rather than just giving an answer to, because as stronger the ceramic, it's going to probably completely cut off your opposite tooth as well. So you need to be more holistic in your approach when you are rehabilitating a case.
Thank you. Moving on with the next question. A question from Dr. Nikita. If we use zirconia post in cast and pour, what is preferred restoration and what kind of luting agent should be used?
So when you're using a zirconia post for a post and core, then again, as I said, with a zirconia post, the kind of restoration that you want to use in the luting agent, primarily now there are zirconia primers. So see, when you're using a zirconia post, you obviously can't air blast it internally inside the patient's mouth. So that all these things are done outside. So you have zirconia primers which are available. So over the post, you apply a zirconia primer. The zirconia primer is a combination of phosphate, the MDH, chemically it is called as the methacryloxy diphosphate monomer. So these zirconia primers which are available in the market, they have to be coated, over which then internal surface of your lithium disilicate ceramic can be a silane coupling agent, and then you can lute the crown. So particularly in such cases, the use of a zirconia post, a zirconia primer is very, very essential to be used. And then you can use a dual cure resin cement. Before that, a silane coupling agent has to be applied, and only then you will lute the restoration.
Thank you. Moving on with the next question. Would you prefer laminates on canine and canine guidance occlusion?
I have already answered this question, that if it's a canine guided occlusion, then if this is my personal choice, I would prefer giving a full coverage restoration, particularly because if it's a laminate veneer, then I am a little doubtful about the debonding, specifically in canine guided. So I would prefer giving a full veneer.
Thank you so much.
Of course, again, the extension of my veneer and the kind of finish lines that I need on my veneer have to be evaluated. So that those are all the clinical situations that you need to discuss, seeing the patient, and accordingly take your decisions.
Thank you, ma'am. Moving on with the next question, a question from Dr. Piyush Dua. Which crown is to be more successful in a pediatric patient?
In a pediatric patient, if I talk about before 12 years, then before the occlusion is developed, then I would obviously want to go in for more conservative crowns and not particularly lithium disilicate or zirconia crowns. Yes, the trend is moving towards a lot of zirconia crowns now of rehabilitating the molars and the, but I would suggest that I would go into a provisional prosthesis first, and then after the occlusion is developed, I would want to go in for more definitive crowns.
Thank you. Next question from Dr. Aradhya Chaudhary. In a deep bite patient with pretty translucent teeth, what kind of crown should be given?
In a deep bite patient with translucent teeth. Okay.
Yes.
Now, I would want to say that when we are talking about rehabilitating a patient with a deep bite, then and the teeth are translucent, the first thing that comes to my mind is orthodontic intervention. So when we are looking at multidisciplinary approach, an orthodontic intervention is very important first. The age of the patient has to be evaluated. What is the age of the patient? The orthodontic opinion has to be taken of opening the bite first, and only then your choice of ceramic material has to be chosen. So this is the first thing that we need to do. Obviously, if the patient is not willing to, or there are constraints, then in that case, if it's a deep bite, as I already particularly said, lithium disilicate cannot be used in deep bite situations. Then in that case, you would want to give a zirconia coping with a layering of a lithium disilicate. So that is your next best option. But obviously, if you're talking about idealistic approach, then it has to be orthodontic intervention, opening the bite, having a favorable occlusion, and then going in for a more favorable aesthetic rehabilitation.
Thank you, ma'am. Moving on with the next question, a question from Dr. Ahmed. As my lab technician is converting my ceramic job into fiber reinforced composite material, since I have no experience with this or peak restorations, what should be my answer to my lab technician?
Can you repeat the question again, Ruby?
Definitely, ma'am. A question, as my lab technician is converting my ceramic job into fiber reinforced composite material. Since I have no experience with these or peak restorations, what should be my answer to the lab technician?
Now, fiber reinforced composites, they are called as seromers or the peak restorations. As I have primarily been into research and as a postgraduate guide myself, peak again is a very, very opaque material. It doesn't have the kind of translucency, and the longevity of peak is still questionable. Even concerning fiber reinforced composites, fiber reinforced composites cannot be used in long-term cases. They can be used for provisional cases. So obviously, I think the person, whoever has asked the question, has to convince the laboratory technician that no, seromers or fiber reinforced have to be very, very conservatively used in certain clinical situations where occlusion is not of high demand. And but it is absolutely not a replacement for PFMs, or for that matter, I would say ceramics. They have to be used very judiciously and only as provisional restorations, not as something which is primarily a long stay.
Thank you so much. Moving on with the next question, a question from Dr. Sharan. What should be the preparation thickness for Emacs layered zirconia coping?
For an Emacs layered zirconia coping. Okay,
yes.
So that means a zirconia coping with Emacs layering. It would roughly range between 1.5 to 2 millimeters. That is the reduction. In the functional cuts, we would at least require a 1.5 to 1.8 kind of millimeter reduction. As I spoke about the reduction essentials, there was a slide. So it goes in the range of 1.5 to 1.8.
Thank you so much, ma'am. Ma'am, there's a humble request from one of the attendees who's asking if you could please arrange a live webinar on bite registration in full mouth rehab cases.
Bite registration in full mouth rehabilitation. Okay, point noted. We'll be working on it ASAP. I don't know whether we are going to be continuing with this lockdown. If you're continuing with this lockdown for a longer period, I will soon speak to Ruben and get things organized.
Super. We'd love to have you once again. Ma'am, moving on with the next question, a question from Dr. Maria Naboya. I got a little bit late into the webinar. No worries. What is the Lisi Press and Celtra Press?
Duo.
Yeah, Celtra Press system all about?
basically, lithium disilicate, which has been conventionally used, is comparatively poor in flexural strength. So Lisi Press and Celtra Duo are the high density micronization silicate ceramics, which have improved strength and improved flexural strength. So that's why they can be primarily used for the posterior zones as well, at least limiting ourselves to the premolars. And these are the newer ceramics, which are silica based ceramics or the lithium disilicate ceramics, which have come. So we know lithium disilicate only in the name of Emacs, but it is not just Emacs, but we have Lisi Press and Celtra Duo as well, which are reinforced ceramics, lithium disilicate ceramics with high density micronization. You can read up the literature, it is there, and it is now coming up slowly, and many of the technicians are using these. And I would say that Lisi Press is something which is extremely translucent and very, very beautiful in its flexural strengths to be used in the anterior aesthetic zone. One of my postgraduate students is doing a research study as well on it. Comparable research study of Lisi Press with Emacs.
Thank you, ma'am. Moving on with the next question, a question from Dr. Ratan Upadhyay. Ma'am, any other factors to keep in mind apart from the age of the patient for replication of the translucency in anterior region?
Any other factors that have to be borne in mind apart from the age of the patient?
Apart from the age of the patient, for replication, for replication of the translucency in anterior region.
Right. So if we have to create that aesthetic realism, or you want the translucency, then it's not just the age of the patient, but obviously the amount of tooth reduction that is required, then the labiolingual thickness of the tooth, which is very important. Your choice of ceramic and your choice of luting agent is also extremely important when you want to replicate the translucency that you desire. Besides the right choice of ceramic material that you're going to probably now bear in your mind after this webinar, I think I have given you that last slide which talks about the conceptualization of everything, wherein it says that, you know, the amount of tooth reduction, your smile line, your adjacent teeth, your occlusion, your type of luting agent, all these factors have to be in sync with each other when you're talking about replicating aesthetic realism.
Thank you. Moving on to the next question. A question from an anonymous attendee. Which type of primer is used most commonly?
Which type of primer? Okay, so that's not something which we have. Monobond Plus, which is used as a silent coupling agent. We have Z Primer 100, which is used as a Zirconia Primer. So these are different primers which are used for the coupling agents or the bonding systems. However, when you're talking about the single cure, when we are talking about the light cured and the dual cured composite resin luting agents, then they have their specific prime and bond systems which are available with them. So be it a single bottle or be it a double bottle of a primer and an adhesive. So for example, if you're talking about Calibra, which is very routinely used, then Calibra has a primer and an adhesive which is a 2-bottle system, and it has to be, it's a prime and bond NT, and you have to mix both together, one drop, and then you apply it on the intaglio surface and onto the surface of your tooth, prepared tooth, and then you etch. So it's a very system specific kind of a thing. As per your comfort level, you have to choose your primer, yes, but it has to be very specific to the kind of system that you're using. And each system has their own brands. I would not want to rate one over the other because that's not why I'm here for. But yes, you have to understand the knowledge behind these systems, and that's how you're going to be using them.
Thank you, ma'am. Moving on with the next question. A question from Dr. Kasina. Which joint is preferred for veneers? Is it butt joint or overlap?
Now, depends again on what is the occlusion which is there, what is the edge-to-edge incisal guidance that we are looking out for. So obviously, when you want, if your centric stop, or rather your centric occlusion is not interfering with the butt joint, then you would go in for a butt joint. But if it is interfering when you're with the incisal guidance, when the patient comes in protrusion, or when it is particularly the kind of mutually protected occlusion that you're desiring for, then you would go in for a wraparound.
Thank you, ma'am. Ma'am, are we taking a short break or can we continue?
No, you can continue.
Thank you so much, ma'am. Moving on with the next question, a question from Dr. Shweta Thakkar. What should be the solution for sensitivity with anterior veneers?
Okay. So now, again, as I emphasize, when you're planning a laminate veneer and when you're evaluating the patient, many a times we observe that the labiolingual thickness of the tooth is comparatively lesser. And when you are preparing the tooth, and when you're kind of not in enamel and you're very close to the dentine, that is the time when your sensitivity starts. So that's why judiciously planning your case for a veneer is very, very important. I would say if your tooth is sensitive, then it would better to go in for a full veneer crown than a laminate veneer. Yes, but if you have preliminary sensitivity, then apply a bonding agent, wait for some time, and then obviously you would want to go in for your veneer luting.
Thank you, ma'am.
Another very important factor which I would want to mention over here is that many a times it is important for us to have a proper seal of the margin. See, most of the sensitivities begin in laminate veneers when you do not have a proper seal. The marginal integrity and the internal adaptation of your veneer prep or your veneer over your prep is extremely crucial. Your bonding system and the way your protocol you're following is extremely crucial. That's why, particularly in laminate veneers, the technique has to be followed to the perfection. And that's when so evaluation of a case, very, very important. And secondly, following your procedure, your luting protocols, and your marginal adaptation, your finish line integrity, all this is extremely crucial for you to get the kind of desired success. And your patient has to be obviously satisfied.
Thank you, ma'am, for the very satisfactory answers. I'm sure everyone's getting just or at least a complete answer to their questions. Now, moving on with the next question. What is the scope of LDS in inlays, onlays, and tabletops?
What is the scope of LDS, lithium disilicate? Okay, so let's talk about inlays, onlays, and tabletops. Now, when we are talking about inlays, onlays, and tabletops, they are conservative preps. Okay, and they are the kind of restorations which are now gaining a lot of popularity. So when we are talking about using lithium disilicate as a choice of material, I must emphasize that the bonding system here is very, very, very important. Also, inlays, onlays, and tabletops primarily have to be in enamel. The finish line has to be integrally in enamel, and the bonding system that you're using. So you use either a light cured or you use a dual cured. The kind of bonding system, essentially with the use of a silane coupling agent, is very, very important. We insist on the HF, that is the hydrofluoric acid etching with the lithium disilicate, and I think they are working wonders, because inlays, onlays, and tabletops with lithium disilicates can be enhanced. Their bond strength is enhanced purely with the type of bonding systems that you're using. So this is something which is working really wonders. Yes, again, used with caution, used in particular favorable occlusion cases, and obviously it has to be primarily in enamel. Only then your bonding systems are going to work wonders.
Thank you, ma'am. Moving on with the next question. A question from Dr. Aparna Deo. Ma'am, do CAD-CAM fabricated all ceramic crowns give a better marginal fit?
Absolutely not. I've done a study and a research on it. CAD-CAM restorations basically do not have better marginal fit or internal adaptation. They're still working over it, but when you're comparing it to a pressable, or when you're talking about conventional procedures, then obviously the marginal integrity and internal adaptation is much, much higher in pressable rather than CAD-CAM.
Thank you, ma'am.
But again, a lot of research is going on in it. But as I have done studies over the past 10 years with my postgraduates, this is what is the information that I have currently.
Thank you, ma'am. We have an array of questions. Quickly, I'd like to tell you the next question. A question from Dr. Dipali Patani. Can Lisi press be used in anterior discoloration cases?
Anterior discoloration? No, my dear. See, it's not about Lisi press being a substitute for Emacs. Lisi press is just a high density micronized lithium disilicate. So it is not a substitute for Emacs, and which is going to mask your underlying tooth structure. I've already given you the answer that if the underlying tooth structure is discolored, then you have various other treatment protocols to mask that underlying tooth structure, and then you're going to choose your ceramic. So be it bleaching, be it the sandwich technique, all these factors are important for you to follow first, and then you're going to use your translucent ceramic.
Thank you, ma'am. Moving on with the next question. A question from Dr. Maria. Do we follow the same protocol cementation of Emacs with Lisi press?
Absolutely. Because they are silica-based ceramics, So it's the same protocol, except for zirconia or metal-based restorations or tie-based restorations, which require the additional tribochemical silica coating or the air abrasion that I spoke to you about by Rocatec Plus or Kojek. These are the ones which follow the same protocol. Only the zirconia or the non-silica based restorations require a different protocol, which has additionally the tribochemical silica coating as well as the zirconia primer, which needs to be alternatively applied.
Thank you. Moving on with the next question, a question from Dr. Thakkar. Once the prosthesis is fabricated with an incorrect shade, a shade correction by technician before final cementation be encouraged?
Absolutely. Absolutely. That's why the technician communication is very, very important. In fact, sometimes I feel that you must send the patient over to your laboratory technician. I think all the laboratory technicians must have a clinical chair with them and have the patient see visually, so that the expertise of the laboratory technician can also be explored upon when they visually see that what is the problem in the shade match. So there's no harm. I don't think you should satisfy yourself with something which is compromised. I think it's very important for you to send it back. And till the time I have always learned in my practice that unless and until your eye still perceives it as a crown, you've not done a good job.
Wow, that's a beautiful answer. Moving on with the next question, a question from Dr. Sharan. How favorable is it to use inlays in endodontically treated tooth?
In endodontically treated tooth, you're not primarily in enamel. So that's the reason I would not prefer using inlays in endodontically treated teeth, because obviously your bonding characteristics are something which are affected. So in those situations, and then your ceramic wouldn't be your choice of material. I think that would be probably you would want to use precious alloys, or you would want to use some other kind of materials for your inlays, not particularly ceramics.
Thank you, ma'am. Moving on to the next question. Would you prefer pressed Emacs or milled Emacs?
I've already answered. Pressed Emacs have better marginal fit than milled Emacs. However, many a times the situation is that when you have posterior zones, then maybe your milled Emacs can be used, but in the anterior zones, marginal integrity is extremely crucial, emergence profile extremely crucial. So pressed Emacs in the anterior aesthetic zone is our choice of technique.
Thank you. Moving on to the next question, a question from Dr. Akib. How do we strengthen ceramics?
How do we strengthen ceramics? Okay, so that's yet another chemistry behind it. So we have a lot of procedures for strengthening ceramic, and I think I'm not
We need
yeah.
another live webinar for
What
it.
I can probably just tell you is that a very simple, I think in the beginning I didn't go into the chemistry behind it, but I just want to explain that ceramics is glass basically. So now when it is in the amorphous stage, it is obviously, it's very translucent and it's not strong enough. But the more crystalline you add on to it, the more filler particles you add on to it, the translucency starts decreasing and you have more of opacity. Now, obviously, with more of opacity, with the filler particles, with dispersion strengthening, crack propagation, all these factors, you would obviously go into strengthening the ceramics, which become more crystalline, more solid structures than amorphous structures. And all this chemistry, basically, there is a transition from translucency to opaque. So if you read about literature and if you read about the history of ceramics, when I was talking and when I was probably, just for the sake, when we started talking about ceramics, particularly is brittle in nature. It was a pot which was made, and that was called as porcelain pot, that is called as clay. Okay, but however, now in the modern times, ceramics is a blend of brittle as well as strengthened ceramics. So if you want glassy structure, it's brittle. You want strengthened ceramics, it's opaque, and there's a lot of chemistry behind it. So I guess I need to do a little bit of PhD of chemistry in strengthening of ceramics to answer this question a little better. But yes, I would do a lot of read up on this and I get back to you next time.
Thank you, ma'am. Moving on with the next question, a question from Dr. Sharan. If you can please reiterate the diluting protocols for IDS crowns.
Do you want me to show you the slide again?
He would love to, ma'am. We would love to.
Okay, just give me a minute.
Ma'am, in the meanwhile, can I ask you the next question?
Sure.
Yeah, it gets very difficult to convince patients if they ever had a fractured zirconia crown. What to do in such situations?
If you have a fractured zirconia crown, then what to do in such situations? How are you going to convince your patient? That's what you're trying to say?
Yes, ma'am, that's the question.
Okay. Primarily, you need to first understand what is the reason of fracture. If it's obviously we all come with warranties from our laboratory technicians and warranty for the kind of ceramic restorations that we are promising to our patients. So first of all, evaluate what is the reason of your fracture. Now, from my experience, I understand that the fracture of a ceramic crown can happen when you have insufficient occlusal clearance or deflective occlusal contacts. That could be primarily two basic reasons. So obviously you go back and search for the reason behind the fracture of the ceramic crown. You remove obviously you need to debond the crown. You need to, don't repair it intraorally. Please don't do that. Remove the crown, understand the reason why the ceramic crown has fractured. If it's insufficient interocclusal clearance, please redo your prep and repeat your impressions. Send it to your lab. I think your lab also gives you a warranty. Please understand that, bear your expenses yourself, and successfully treat your patient. One very important thing is deflective occlusal contacts is also something which are premature contacts also have to be. So you have to adjust your occlusion properly, and you have to be very careful in all those things. So all these things are primarily important behind the failure of restoration. So understand your failure. We learn from our failures. It is okay to probably bear the expense of yet another crown, but basically you need to satisfy your patient, because that patient is going to give you more blessings and get you more patients.
Truly. Ma'am, I believe now you could now answer to the question, which was luting protocol for IDS crowns.
Yes. So when we are talking about luting protocols, let us understand that we begin with the luting. We begin with the 5%. Let's look at the top right corner. You have the 5% to 9% etching of the hydrofluoric acid, which you insist that the lab does it. If the lab doesn't do it, you do it at the chair side. It is available. So it is particularly the pre-etch of the intaglio surface of your restoration, which is important, be it a veneer or a crown. After that, you apply a silane coupling agent, Monobron Plus, and lot of other silane coupling agents are available in the market. So you apply the silane coupling agent onto it, air dry it, and then wait for some time. So this is the first thing that you need to do. So after the hydrofluoric etching, you wash the veneer or wash the crown and clean it, air dry it. Again, apply the silane coupling agent and then air dry it. Now air dry it and wait. So this is the preparation of your restoration. Now let's look at the tooth. When you're looking at the tooth, you are going to do a etching of the tooth. Now you are primarily in enamel, so you have to etch the tooth. I like to etch the tooth myself. So etch the tooth with 37% phosphoric acid, whatever the kind of bonding agent, whatever the kind of etchant that you're using, it has to be primarily 37% phosphoric acid. Then you apply your bonding agent depending on the system that you're using. Now let's understand that if you're using a light cured system or a dual cured system, accordingly it will change. So let's just take it up as a dual cured system. When you're using a dual cured system, you mix your prime and bond NT, mix both the bottles, one drop of your prime and bond primer and your one drop of your adhesive, mix it and apply it onto your tooth surface, as you can see in this, and light cure it. Now we go to the luting procedure. So now your restoration is already prepared. Now you're going to be loading your toothpaste system. Your toothpaste have to be mixed properly. That is the base and the catalyst paste of your dual cure. You mix it, you load it onto your put to your excess and finally cure it all over from all the sides, palatal side. So if it's a full crown, it's a palatal side 10 seconds cure, a labial side 10-second cure, and that's how you wait. Now if you're using a dual cured, obviously it's a two-paste system that you're mixing and then loading the luting agent. If it's just a light cured, it's going to be 10 seconds. If it's a full crown, it's a palatal side 10 seconds cure, to give more room or more, you just need to load the basic paste and then you light cure it finally. So that's what is your protocol you need to follow for a particular lithium disilicate. Again, I emphasize pre-etch with 5% hydrofluoric acid, done in the lab or the chair side, followed by a silent coupling agent, has to be applied to the intaglio surface of a lithium disilicate. And obviously your basic protocol on the tooth has to be followed with the kind of system or the bonding luting agent that you are using.
Thank you, ma'am. I hope your question was duly answered, Dr. Sharan. Moving on to the next question. Can ceramic onlays be used for full mouth rehabilitation?
This is something like tabletop restorations. Yes, if we are primarily looking at less of interocclusal clearance, then and in short clinical crowns, yes, ceramic onlays can be used like they're typically called as tabletop restorations, and then they can be used in the posterior zone for full mouth reconstructions. Absolutely.
Thank you very much, ma'am. Moving on to the next question. A question from Dr. Aparna Deo. Ma'am, does zirconia cause wear of opposing tooth?
Absolutely. Yes, it does. Zirconia does cause the wear of opposing tooth. That's what exactly I said, that it's very, very important for us to judiciously use zirconia. Zirconia does cause the wear of opposing tooth. That's why adjusting your, see, primarily zirconia is supposed to be used with layering. So lithium disilicate is softer and kinder to the opposite dentition. So that's how using monolithic zirconias or just pure zirconias are not the preference of choice. As I said, one of the earlier questions also, that Bruxer, when you're talking about reconstructing absolutely all the posterior zones, when you have upper Bruxer crowns, lower Bruxer crowns, and you have zirconia cutting zirconia, then it's different. But when you have a zirconia which is opposite a natural tooth, then you have to use it very much with caution. So it's preferable. So even in PFM restorations, you have an internal metal coping and over which is feldspathic ceramic. But zirconia is very, very, very tough and very strong. So it's obviously going to slice through your opposing tooth. So you have to be very, very judicious. You have to give your patients, night guards, protective night guards, particularly when you are anticipating parafunction. And you have to understand that we are not here to ruin the opposite dentition when you're selecting your ceramics.
Thank you, ma'am. Before we move to the next question, I'd like to tell you that we have a number of thank you messages from our participants. Thank you so much, ma'am. Thank you so
Been a
much.
pleasure.
Thank you, ma'am. Moving on to the next question, we have a question from Dr. Jacob PC. Is Tribochemical available in India?
Yes, sir. Dr. Jacob has been my guide and my very, very, I would say, somebody whom I look up to. So yes, Dr. Jacob, Tribochemical is available in the form of Rocatec Plus, marketed by 3M SP. Yes, sir. It has been available. It is available.
Thank you, ma'am. Now that you said, I'd like to also say that Dr. Jacob has written that it was an excellent presentation, Dr. Saloni. The decision to use Emacs or Zirconia is a tough one. Thanks for simplifying it.
Thank you so much. I would also like to mention, when I'm speaking about my guides and mentors, I would also like to mention that Dr. Sabita Ram has always influenced my life professionally. She has really, really been very, very influential on me, and I thank her for all the advices and all the guidance that she has provided to what I am here today. Thank you so much, ma'am. If you are hearing me today here, thank you so much for all that you have done to me. And also my mom, who was a prosthodontist. She's no longer here today, but I have her blessings always with me.
So sweet. Thank you, ma'am. Moving on to the next question. Can resin modified ceramics be used in full mouth rehabilitations?
Resin modified ceramics. See, now resin modified ceramics are the latest generation ceramics, which are the nano ceramics right now. So they are still under a lot of, I would say, research. These are the third, when I talk about the classification, those are the resin matrix ceramics, as I said, wherein you have the resin penetrating matrix and internally the ceramic particles are dispersed. So can they be used in full mouth reconstruction? Yet a lot of research needs to be done on the resin matrix ceramics. We have particularly under the name of Lava and Ultimate and all these, but yes, to be used with caution, yet needs to be researched upon. I think I'm working on it.
Thank you, ma'am. Moving on to the next question. Is a monolithic zirconia crown a better option for posterior teeth restoration or layered?
Layered always. See now, there is a lot of trend as I'm saying that zirconia wants to be more translucent and lithium disilicate wants to be, that's the war. Lithium disilicate wants to be stronger, and zirconia wants to be more prettier. But when you're talking about monolithic zirconias, yes, they are marketing it as they can be used in posterior restorations, but maybe just probably first molars and second molars, not premolars, because they are not, still they cannot parallel the aesthetics which can be given with veneering. So when we are talking about zones which are not following in the anterior aesthetic zone, and when it's a posterior zone, as I said, first or second molars, yes, maybe they can be used for posterior zones. Yes.
Thank you, ma'am. Next question from Dr. Huma Nawaz. Ma'am, which material is best to use for until a bridge in posterior arch? I'm not sure about the question.
Okay, so what material is preferable to use if you have a 3-unit fixed dental prosthesis? Bridge means a 3-unit fixed dental prosthesis. As I said, you can use zirconia for a 3-unit, as zirconia coping for a 3-unit layered with a veneering ceramic. But if there is a compromised occlusion or the occlusion is demanding, then PFM still remains my gold standards.
Thank you, ma'am. Moving on to the
I
next.
think there are beautiful restorations that you can do still with PFMs as well, particularly in the posterior zone. So posterior zone, when you have really, demanding occlusion, yes, PFM still remain the choice of, because they are promising in longevity and they're here to stay.
Thank you, ma'am. Moving on to the next question. A question from an anonymous attendee. In posteriors, can we use zirconia FPD in a normal patient? Should I tell the patient that there is a chance of wearing of opposing dentition?
If it's veneered ceramic, then I don't think there should be a problem. But if you're using monolithic, then yes, it is important that you make the patient aware. But if it's veneered, then I think it's fine.
Thank you.
As I said, no high points, adjustment of occlusions, mutually protected occlusion, no deflective contacts. All these things are very, very crucial when you plan your prosthesis and you are rehabilitating a patient. So all these are going to actually enhance your longevity and safeguard your dentition.
Thank you, ma'am. Moving on to the next question. In luting lithium disilicate crown, tooth should be etched followed by bonding agent, or can we use 7th gen bonding agent directly without an etchant?
Yes, you can. But if you are primarily in enamel, as I said, I personally would like to etch the enamel because always etching the enamel will enhance your adhesion. So even if you're using a 7th generation bonding agent, I would preferably etch the enamel. But it is again a preferential choice. But primarily, if it is enamel, then you must etch the enamel. If it is dentine, then it's okay if you do not etch it. Then you can probably just use the bonding agent, 7th generation bonding agent, which is a self-etch primer and adhesive one bottle system. Yes.
Thank you, ma'am. I'd now like to take a few questions that we've received on YouTube Live. What is the perfect time or light to take shade?
What is the perfect time? Bright sunlight. Absolutely bright sunlight, but there are color corrected, so there are corrected lights available as well. So obviously we are not the types who are going to be practicing throughout the day, and at night we are going to say bye-bye to our practice. But there are color corrected lights as well available, which would give you the kind of visual like a daylight. So you can probably, have color corrected light sources available as well. But yes, obviously it is in front of the daylight. That is what the sunlight is, what you have to take the accurate shade. You also have the neutralization. So you look at a blue or look at a gray and neutralize your shade, because constantly if you're trying to look into and trying to take the shade, it's going to probably, have a bias. You need to neutralize and look at gray or blue and then again get back to your shade.
Thank you, ma'am. A question from Dr. Neeraj Gupta, once again on YouTube Live. On vital teeth, do you prefer etching for zirconia crown on molar?
Etching on vital teeth for zirconia crown? Absolutely not. For a zirconia crown, why do we need etching? For zirconia, we are not, if you're not going to be using, you probably use a resin modified glass ionomer or a glass ionomer for a luting agent, then why do you need etching? No, you don't need etching. You need etching particularly when you are in enamel, when you are using a dual cure or a light cure luting agent system. That's when you etch the tooth. If you're using a zirconia, and if you're using if you're in the posterior zone, then there is no need of etching.
Thank you, ma'am. I guess with that, we come to an end. I'd like to tell you and all the participants that you've answered to more than 50 questions, which is an outstanding number. And you've also answered them thoroughly, properly, not giving them a complete idea and a satisfied answer. Ma'am, I'd also like to bring to your notice that Dr. Sabita Ram was very well present for the presentation. She's also said that she's thanking you and that you were amazing. Along with Dr. Sabita Ram, we have a number of thank you messages from a lot of people who've attended. Thank you so much, ma'am. It was definitely a wonderful session. On behalf of Team DentistChannel.Online, I'd like to take this opportunity to thank you and to all the participants for waiting so patiently and listening to all the answers. Some of them I've asked just one question, but then they've waited for the entire seminar. I think that's really beautiful. And yes, friends, you can get in touch with Dr. Saloni Mistry. She'd love to get in touch with you. That's her email ID. I'll give you 1 minute, maybe you can note down.
It was indeed a pleasure interacting with all. I think in this quarantine times and lockdown times, I also browsed through so many things. There were and that's when you realize that what you know is just a drop of ocean, a drop in the entire ocean. It's an ocean of knowledge, and what you know is just a small drop. So I would like to tell all my dear postgraduate students, my colleagues, my friends, that I think you can just keep on reading, share your experiences, and it's an infinite kind of a thing. I always say that learning is something which is infinitesia. It is not going to stop anywhere. You can learn to infinity. Thank you so much for giving me this beautiful opportunity. Looking forward to answering your questions, looking forward to sharing all my knowledge and whatever my experiences are with all of you all. Thank you so much. Once again, stay safe, stay healthy until we connect back, all of us together.
Thank you so much, ma'am. Friends, you can definitely get in touch with Dr. Saloni. She is very much active on social media as well. You can follow her on her Facebook page. You can follow us, DentistChannel.Online, for the upcoming webinars and for a number of webinars that we are hosting in this week and till the lockdown ends. We'd love to have each and every one of you once again for the upcoming webinars. Let me tell you that you all deserve a certificate of participation for being so attentive, so lovely. Also, on behalf of Dr. Saloni, I'd like to thank each and every one of you for being so patient. That is very important. You've asked one question, but you made sure that you wait till all the answers that were asked. Friends, with that, we come to an end. Thank you, Dr. Saloni, once again. It was a pleasure having you. We look forward to having you for many more events.
Thank you, Dentist Channel Online. Thank you, everybody. Good luck and stay safe.
Thank you so much, ma'am. Goodbye, friends, and may you all have a good evening. Thank you.